In this lecture, we're going to be talking about blood pressure and blood flow. So we'll be talking largely about the vascular function of the cardiovascular system. So we have the flow rule. First of all, circulatory system, as we've said before, is a closed system. That is, unless somebody is bleeding heavily, we have a certain fixed amount of blood that keeps circulating around and around through the cardiovascular system. And there's no way of quickly increasing or decreasing that volume. The pressure in the system is the force exerted by the blood. And of course, that starts out with the cardiac contraction giving the force to the blood. And pretty much common sense that the flow occurs from regions of high pressure, that is the arterial side of the system, to regions of low pressure, that is the venous side of the cardiovascular system. Flow equals the change in pressure divided by the change in resistance. So you have a certain amount of pressure coming in here, and as shown here, we have, as we referred to already in the previous lecture, a certain amount of elastic recoil of the large vessels, acting as a pressure reservoir, that is pushing the blood down through these areas of resistance. And as we'll see, the arterioles are where most of the resistance occurs in the cardiovascular system. So you have a resistance occurring along all blood vessels, but again, most of it is occurring here because we have smooth muscle here that the autonomic nervous system can control. And as you've learned in your lab, a change in radius produces a change in resistance. As radius goes up, resistance goes down, and flow goes up, and vice versa. So the pressure gradients of the cardiovascular system, we have going from high pressure to low pressure, as we said before. And this produces a flow that we call bulk flow. That is, large quantities of blood are moving from one region of the cardiovascular system to the next. The heart creates this gradient for bulk flow, and the gradient must exist throughout the circulatory system to maintain flow. So pressure is higher here than here, higher there than here, higher here than here, higher here than here, higher here than here. This is, of course, what keeps blood moving continuously throughout the cardiovascular system. So let's take a look at the systemic circuit. The systemic circuit, go back a couple of slides here. The systemic circuit is this whole part between the left heart and the right heart. The pulmonary circuit is what exists between the right heart and the left heart. So we're most interested in the control of blood flow through the systemic circuit. So the pressure is the driving force. We have high amount of pressure in the left ventricle, pushing blood through the systemic circuit and coming back to the right heart. Pressure gradient is pressure in the aorta minus the pressure in the vena cava. So as stated here, aortic pressure 85. Mean arterial pressure generally is about 90 to 100. We have 85 minus the pressure here in the right atrium, which is at about 0. So the pressure gradient is 85 millimeters of mercury. If we have the values that I have here in this slide, 90 minus 0, we end up with 90, but it's, again, very close to the 85. On the pulmonary circuit, it's the same idea, but we have much lower pressures overall. The right ventricle being much thinner in terms of the wall thickness than the left ventricle develops a much lower pressure, about 15 millimeters of mercury versus about 90 to 100. The pressure, again, coming into the left atrium from the pulmonary circuit is about 0, so we only have about 15 millimeters of mercury pressure in the pulmonary circuit. Blood pressure coming into either systemic circuit or pulmonary circuit indicated here. The greatest drop in pressure, this amount here, this drop in pressure, is greater in the arterioles than in any other area. Pressure drop in the capillaries is smaller, and pressure drop in other parts of the circuitry are smaller. So the arterioles is where we have the greatest resistance. Let me go back to one of our first slides. That is because in the arterioles, right before we get to the capillary beds, we have basically valves. There's smooth muscle that is regulated by the autonomic nervous system that can increase resistance and therefore decrease flow. And that is why we have this very large drop in pressure here. Even in the pulmonary system, the greatest drop in pressure, meaning the greatest presence of resistance or the greatest magnitude of resistance, is still in the arterioles. It's just that we're dealing with smaller pressures. So the pressure in the systemic circuit is much greater than that in the pulmonary circuit, and that's it, of course, illustrated here. The flow through the circuits is equal. We have lower pressure in the pulmonary circuit pushing the same amount of blood through the lungs as we have going through the systemic circuit, because there is a lower resistance. So we don't need as much pressure to push blood through the pulmonary circuit. And in the systemic system, we have much greater resistance, therefore producing the greater pressure. Factors that affect the resistance to flow. The largest one is radius of the vessel, or diameter of the vessel, if you like. In arterioles and small arteries, the radius is regulated by both extrinsic and intrinsic factors. The extrinsic factors include the sympathetic nervous system, as well as hormones. Intrinsic factors include metabolites. That is, buildup of CO2, buildup of potassium, metabolic byproducts, a reduction in oxygen. All of these act as intrinsic mechanisms. And quite often we refer to this also as autoregulation. The idea that we don't need some factor outside what's going on right there at the vessel controlling the vessel. The length of the vessel can affect resistance, as you saw in your lab, but of course that's not regulated. The length of a vessel remains constant throughout life, except for development. The viscosity of the blood, that is how thick the blood is. The number or amount of red blood cells and proteins, as that goes up, the blood becomes more viscous. And as it goes down, the blood becomes less viscous. Greater viscosity leads to greater resistance. But again, that's not something that the body generally regulates. It's the radius of the arteriole is what the body regulates in order to regulate vascular resistance. So we have what we call vasoconstriction, where you decrease the radius, which is an increase in the resistance. So vasoconstriction is an increase in resistance. Therefore, an increase in blood pressure. Vasodilation is an increase in radius, therefore a decrease in resistance. So vasodilation is a decrease in resistance and a decrease in blood pressure. And as we said before, the pulmonary circuit has less resistance than the systemic. Therefore, there is a lower pressure gradient required to push blood through. Now, in cardiovascular physiology, we end up talking about total peripheral resistance, because we can't really look at resistance very conveniently in, let's say, the arterioles going to the GI tract, or the arterioles providing blood flow to the brain, or the arterioles going to the kidney. When in a clinical setting, when you record blood pressure from someone's arm, you're looking at the total resistance of the entire systemic circuit and its influence on the blood pressure. So it's the combined resistance of all the blood vessels within the entire systemic circuit is what we mean when we say total peripheral resistance. It's resistance across a network of blood vessels. across all of these blood vessels. And, of course, the flow through the network varies with resistance. We talked in a previous lecture about the idea that we have parallel flow. That is, the flow through this vascular bed parallels the flow through this one, as well as this one, as well as this one. And if you regulate the resistance of any of these individually, it will alter blood flow here, but it's also, by increasing resistance here, decreasing blood flow, but it's producing a greater pressure reserve to push blood through these others. We talked about that again in the previous lecture in parallel regulation of blood flow. So if you have vasoconstriction in the entire network, there is an increase in resistance and a decrease in flow, and vice versa. So how do we relate these pressure gradients and resistance in the systemic circuit? Well, we said already, flow equals the pressure gradient divided by the resistance. What's the flow? It's the cardiac output. We've already studied this. This is, of course, heart rate times stroke volume. Change in pressure is the mean arterial pressure, or the pressure gradient, I should say, and the resistance is the total peripheral resistance. So this equation is the same as this equation. It's just the bottom equation is one that's much more meaningful to us from a standpoint of cardiovascular function. That the cardiac output, the flow through the system, equals the blood pressure divided by the total peripheral resistance. Let's have a brief overview of vasculature. The arteries carry blood away from the heart. They have to be thick-walled in order to withstand the large amount of pressure coming out of the heart, as well as, of course, some of the thickness of the wall is smooth muscle that is involved in providing resistance. We have the microcirculation, which consists of the arteries. Again, these are the main site for regulation of resistance. And the capillaries, which are a site of exchange. So capillaries are very thin-walled. We want substances to be able to diffuse very easily across the walls of the capillaries. Venules are a way of collecting the blood from the capillaries, and then they converge, of course, into the veins, which return the blood to the heart. Arteries act as a pressure reservoir. We mentioned this in the last lecture, that especially the aorta and the larger vessels have very thick, very elastic walls. So as blood comes in, so we have, let's say, if this is the aorta, blood coming from the left ventricle comes in, and that pressure stretches the walls of the aorta out. Now, of course, there is blood that continues to flow through, but this pressure will then later recoil inward once the aortic valve is closed and help to maintain that continuous flow throughout the systemic circuit. And we talked about this again in the last lecture. So arteries have very low compliance. That is, they do not stretch outward very easily, but that means, of course, that they recoil quite forcefully. They expand as blood enters them during systole, and then they recoil during diastole. And this is why, when you have normal blood pressure, 120 over 80, this is why the diastolic pressure only goes down to 80 rather than going down to a lower volume or lower pressure, because this inward recoil helps to keep the pressure up. So rapid transport pathway, large diameter, fairly small resistance. Most of the resistance, again, is in the much smaller arteries, the arterioles. And the walls contain a fair amount of elastic and fibrous tissue. They have to, because they're under high pressure. So let's take a look at the idea of vascular compliance. It's a measure of how the pressure of a vessel will change with a change in volume. So arteries have low compliance. A small increase in blood volume causes a large increase in pressure. Veins, on the other hand, have high compliance. A large increase in blood volume is required to produce a larger increase in pressure. Highly compliant vessels, such as large veins, can act like reservoirs of blood. They actually store the blood. For this reason, we call them capacitance vessels, because they have a ability to store a capacity of blood. About 60% of the blood volume is, at any moment in time, in the systemic veins, or at least during rest, that is the case. Now, of course, that means that that's a volume of blood that is able to come back to the heart. And since more than half of the blood is in the veins are important in terms of controlling return of blood to the heart. And as we saw when we talked about the Frank-Starling law of the heart, can affect ventricular contractility. Arterial blood pressure. What we're really looking at more than anything is the pressure in the aorta. Even when somebody puts a blood pressure cuff on your arm, the artery that we're recording the pressure from is very, very close to the aorta. But that is, of course, upstream of all of the other blood vessels. So is where the pressure is going to be the highest. It varies with the cardiac cycle. Systolic blood pressure, which occurs, of course, during ventricular systole, hence the name, is the maximum pressure. And it's due to the ejection of blood into the aorta. Diastolic blood pressure, which of course is occurring during ventricular diastole, is the minimum pressure. So again, if you have 120/80, the systolic pressure is the 120, the diastolic pressure is the 80. It's not zero. Diastolic pressure does not go to zero, again, because of the elastic recoil of the arteries. Mean arterial pressure can be calculated by taking the diastolic pressure and adding 1/3 of the difference between the systolic and diastolic pressure. It's also called the pulse pressure, the systolic pressure minus the diastolic pressure. If this is the pressure pulse wave, the systolic minus the diastolic. Dividing that quantity by 3 and then adding it to the diastolic pressure gives you, if this is a graph of pressure and blood pressure is going up and down around that, it gives you the best average of this total amount of pressure by calculating it this way. So let's take a further look at mean arterial pressure. Mean arterial pressure is the product of cardiac output and total peripheral resistance. So it's pressure, the relationship between pressure, flow, and resistance. So pressure equals flow times resistance. Cardiac output, we've already studied this, equals heart rate times stroke volume. Total peripheral resistance, we've just finished talking about. 60% of it, again, is due to the arterioles. So we talked about the pulsatile nature of blood pressure. Blood pressure going up and down here. If you notice this pulsatility, that is the change between systolic and diastolic, really is minimized almost down to zero by the time the blood is leaving the arterioles, and that is because we have so much resistance there. By not only reducing the overall mean pressure, it is also reducing or dampening the pressure fluctuations. So the mean pressure drops from about 90 down to about 40 millimeters of mercury. And as I said before, we'll talk about a bit more detail again in a few moments. Resistance is regulated. Basically, the smooth muscle here on these arterioles acts as regulators of resistance by altering the radius of these arterioles. So how do we change the arterial radius? Well, it's due to the contractile state of smooth muscle in the wall of the arteriole. So in our diagram here, these little clamps that we have in a little cartoon diagram to indicate the means of changing diameter. So we have smooth muscle in the arterioles here that can change the radius of each of these groups of arterioles coming into their respective capillary beds. So the arteriolar tone, what we mean by that is the level of contraction, or the radius, of these. And of course, it's dependent upon, again, we keep seeing this pattern, extrinsic and intrinsic influences. Extrinsic influences are, of course, the sympathetic nervous system, Hormones can as well. We'll talk about that later. Some of it we'll even talk about once we get into the renal system. And intrinsic influences, which is, of course, are largely related to metabolites. So vasoconstriction is an increased contraction or decreased radius. We've already talked about these terms before. Vasodilation is a decreased contraction or an increased radius. Vasoconstriction increases resistance. Vasodilation decreases resistance. The intrinsic regulation are metabolites from nearby tissue. Obviously, a greater level of metabolic activity going on, let's say here in cells, skeletal muscle cells, they're going to need more oxygen, more nutrients being provided to them. So those metabolites that are a result of the consumption of oxygen and those nutrients build up, and they act as a signal that cause the capillaries as well as the arterioles leading into them to dilate. And then we have sympathetic nervous system and hormones that can act as extrinsic regulators. So we need to introduce a couple of terms. First one is active hyperemia. Whenever you see the word emia, it means it's referring to blood. Hyperemia is referring to increased blood flow. Active, of course, whenever we have the word active in physiology, we mean it's using energy. So it's an increased blood flow due to increased metabolic activity. So that's where the energy comes in. Increasing metabolic activity and the surrounding tissue, those metabolites are going to cause increased blood flow. So normally it's a steady state. That is, the amount of oxygen delivered to the tissue is coming as fast as it's being consumed. The amount of CO2 being taken up by the blood from the tissue is being removed as fast as it's produced. That's why we call it a steady state. But if you increase metabolic rate, the oxygen consumption is increasing. So we need to provide more oxygen to the tissue. And of course, the CO2 production is increasing. So we need to have more blood flow to remove the CO2. So active hyperemia, these changes associated with increased metabolic activity cause vasodilation. Vasodilation, of course, means increased blood flow, hyperemia. The factors that cause this, decreased oxygen, or what we call hypoxia. Of course, it's because the tissue is more metabolically active, consuming more oxygen. Increased CO2, tissues consuming oxygen and producing carbon dioxide at a higher rate because it's more active. Metabolically active tissues tend to release more potassium. Makes sense. We've already talked about that in terms of electrically excitable tissues, that there's potassium release when they're more active. Hydrogen ion production goes up as a result of metabolism, which decreases pH. So all of these factors are factors that produce active hyperemia. Changes that are associated with decreased metabolic activity generally cause vasoconstriction, and the largest factor there is when oxygen level goes up. It indicates a reduction in metabolic activity and therefore a reduced need for blood flow. So this is active hyperemia. The next topic we need to deal with is reactive hyperemia. This is increased blood flow in response to a previous reduction in blood flow. Most of you have already experienced this. You go out into really cold weather, especially if you don't have your hands covered with mittens or gloves, and your blood vessels in your skin constrict to try to hold on to body heat. And when you go inside, sometimes your hands will actually start feeling tingly with that increased blood flow because the tissue, skin, has had a decreased blood flow. And of course, it has some metabolic needs. Even though there's not a lot of metabolism going on, the skin cells still need some blood flow. So as soon as you step into a warmer environment, which stops the vasoconstriction from reducing the blood flow to the skin, you have an increase in blood flow. And your hands quite often get very red as a result of this. So if you have a blockage of blood flow to tissue, that's referred to as ischemia. metabolites increase and oxygen level decreases. Now, what you want to have is vasodilation, but in order to correct this. But if vasoconstriction is going on, so you have a reduction in blood flow, these metabolites will continue to build up. As soon as the vasoconstriction ceases, you're going to have vasodilation. So, for example, during a thrombus or a blood clot, once that blood clot is removed, then you're going to have the vasodilation as a way of trying to restore the normal oxygen metabolite concentrations. Or, as I said, the response that you get in terms of cold temperature. As soon as you release the blockage, there's going to be an increased blood flow due to the lowered resistance. The metabolites are going to be removed, oxygen will be delivered to the tissue. So after the thrombus or blood clot is removed, or once you are exposed to a warm temperature after being exposed to very cold temperatures. Now, in previous lectures, we did not talk about smooth muscle. It was covered in the textbook in the chapter on muscle physiology, but we did not talk about it in lectures. Smooth muscle, of course, contracts just as any muscle does, but the mechanics of how it contracts is a little different because of differences in the organization of actin and myosin. But one of the unique things about smooth muscle is it has what we call the myogenic response, which is that you get a change in vascular resistance occurring in response to stretch in the absence of any other external factors. So if you have a blood vessel that gets stretched open larger because of greater pressure, the smooth muscle will try to contract due to that stretch. What happens is the stretching opens pressure-sensitive ion channels, stretch-sensitive ion channels that allows more calcium in and causes the smooth muscle to contract more forcefully. And this myogenic response is involved in autoregulation of blood flow. So you have our myogenic response in smooth muscle we've talked about. As the perfusion pressure or blood pressure, the pressure of the blood in the arteriole goes up, it stretches the arteriole or smooth muscle, which causes it to constrict, increasing resistance, which decreases flow. And of course, here's a good example of negative feedback. We started out with an increased flow, and we end up with a decreased flow. So it's a way of auto-regulating blood flow within the arteriole. Blood flow is regulated differently during exercise. Cardiac output increases during exercise, but the distribution of blood flow does not increase proportionately. Remember, we have the parallel arrangement of blood vessels in our body, that different vascular beds going to different organs are arranged in parallel. So those blood vessels taking blood to the skeletal muscle dilate, as do the coronary vessels. But blood vessels going to other parts of the body constrict. So we call this independent regulation, the idea that these two vascular beds are regulated differently. What it does is it sends more blood to the muscles, both to the heart as well as to the skeletal muscle. This is in part due to the sympathetic nervous system. Sympathetic nervous system controls the radius of arterioles. So norepinephrine from sympathetic postganglionic neurons it activates alpha-adrenergic receptors, primarily alpha-1 receptors, and this causes vasoconstriction. Activation of the alpha-1 receptors activates IP3 and diacylglycerol, which we studied way back in Chapter 5. This causes smooth muscle to constrict, which of course increases total peripheral resistance and increases blood pressure. So what happens is you're reducing the amount of blood going to certain organs. You're reducing the amount of blood going to the GI tract and kidneys, for example, which means there is, first of all, more blood available to go to the skeletal muscle, as well as more pressure available to push it into the skeletal muscle. And again, this is independent regulation, the fact that one vascular bed is responding differently than another one. But of course, it's a way of providing what the skeletal muscle needs. This is in part due to the fact that the distribution of the receptors varies. That we have both in skeletal and cardiac muscle, there were both alpha receptors as well as beta-2 adrenergic receptors. Norepinephrine, coming of course primarily from sympathetic postganglionic neurons, binds mostly to the alpha receptors and causes vasoconstriction. Epinephrine, coming from the adrenal gland, binds both to alpha and beta-2 receptors. And the alpha receptors, just like with norepinephrine, it causes vasoconstriction. But causing vasoconstriction in other organs. The skeletal muscle has a lot of beta-2 receptors. And beta-2 receptors activate the cyclic AMP system, or the cyclic AMP cascade, which causes vasodilation in blood vessels in the exercising muscle. So this is how we can increase resistance in some blood vessels and decrease resistance in others, providing blood flow to the muscle that's exercising, to the muscle that has a higher metabolic demand and therefore needs more blood flow. This is in part due to the fact that epinephrine has a greater affinity than norepinephrine for beta-2 receptors. So the effect of epinephrine on the radius of arterioles is dependent upon the concentration. At low concentrations, it's binding primarily to beta-2 receptors and causes vasodilation. At higher concentration, it binds to both alpha and beta-2 receptors. Remember, it has a lower affinity for alpha receptors. Therefore, it only will bind to alpha receptors when the concentration is higher. So this is going to cause vasodilation in skeletal and cardiac muscle vascular beds, that is, in the coronary vascular beds. Decreasing peripheral resistance in those areas, as well as helping to decrease overall total peripheral resistance. Causing vasoconstriction in most other vascular beds, which is going to maintain the overall total peripheral resistance, maintaining blood pressure, helping to push more of the blood toward the skeletal muscle. The dominant effect is usually vasoconstriction. So let's take a look at hormones that affect the arterial radius and mean arterial pressure. Epinephrine, we've already talked about, is released from the adrenal medulla when the adrenal is activated by the sympathetic nervous system. Vasopressin, also called ADH, or antidiuretic hormone. We'll talk about that more in the renal system. But antidiuretic hormone is secreted by the posterior pituitary, and it increases the reabsorption of water by the kidneys. So you're retaining water volume. What it's doing is minimizing the loss, but you're retaining water volume. Water that's being retained by the kidneys is increasing plasma volume. And of course, if you're increasing plasma volume, you're increasing blood volume, or at least preventing it from decreasing. Also, ADH causes vasoconstriction. So it both helps to retain plasma volume as well as increases total peripheral resistance because it causes vasoconstriction. Angiotensin II, we'll talk about this at much greater length when we get into the renal system. But it's synthesized from angiotensinogen, which is a precursor released by the liver. So angiotensinogen is a protein released by the liver. An enzyme called renin that's released by the kidney. If you think about the name renin, it sounds like renal, which of course refers to kidney function. Renin is an enzyme that converts angiotensin into angiotensinogen into angiotensin 1. Another enzyme, which we abbreviate as ACE, stands for angiotensin converting enzyme, converts angiotensin 1 into angiotensin 2. Angiotensin II causes vasoconstriction. It causes vascular smooth muscle to constrict, which of course is going to increase total peripheral resistance. So these are some of the hormonal extrinsic factors that affect blood pressure. Let's take a look at capillaries. There's two different types, what we call continuous and fenestrated capillaries. Continuous capillaries have walls that have very, very tiny gaps in them, whereas fenestrated ones have very large gaps, what we refer to as fenestrations. The continuous capillaries are the most common. They have these small gaps between the endothelial cells, and they allow very small water-soluble molecules to move through. So very small openings allow only very small molecules. These occur, of course, throughout the body. Fenestrated capillaries have these large gaps, or what we call fenestration, that of course are going to allow much larger molecules through, such as proteins. These tend to occur in organs such as the liver that synthesize a lot of proteins, and some of the proteins are moving into the blood from cells of the liver, and some, of course, are moving out as the liver works on them. But obviously, you're going to have different type of exchange going on depending upon if the capillary is continuous versus fenestrated, because a continuous capillary is only going to allow very small molecules to pass through. Now we're going to get back to resistance. There is local control of blood flow through the capillary bed. So in this case, we're more interested in intrinsic, although there's going to be some extrinsic factors that are involved. I'm going to change my pen color here because I'm running into problems with reds and blues. But the arterioles and the metarterioles, let's talk about these. These are arterioles here, and this is a venule here. So we have an arteriole. The arterioles send branches off. Those branches are what we call metarterioles. The metarterioles can act as shunts between the arterioles and the venules. There are what we call precapillary sphincters that are small bands of smooth muscle where the capillaries branch off from the metarterioles. If there is low metabolic activity in this area of tissue, there is very little need for blood flow, so blood will be shunted through the medarteriole and return back through the venous system. If there is high level of metabolic activity in this tissue, what will happen is that these precapillary sphincters will relax, allowing a lot more blood through the capillary beds. And in fact, most of the blood will go through the capillary bed and not go through the medarteriole. So the medarterioles are acting as a shunt if there is high resistance due to constriction of these precapillary sphincters, and just a way of getting the arterial blood back to the venous side of the circulation. If there's a great deal of metabolic activity, these precapillary sphincters relax, allowing most of the blood to go through the capillaries and not through the medarteriole. Now we need to talk about movement of material across the capillary wall. So we're interested in the exchange of material. When I say material, I mean things such as oxygen, CO2, glucose, all of the substances that the tissues need to maintain their normal activity, as well as giving up metabolites that are going back to the bloodstream to be eliminated by the renal system or the lower GI tract. So you have bulk flow of fluid. That is, there is a large quantity of fluid coming through here that is coming through our medarterioles again and capillaries, and then there's going to be a certain amount of exchange. So you have movement of water and solutes, that is, substances that are dissolved in the water. Water is considered a solvent. And it's going to move due to, of course, pressure gradients. Everything always moves due to pressure gradients. So there are two processes that we talk about, filtration and absorption. Filtration is movement of material from the blood supply from the blood supply into the tissue. So it's movement out of the capillary. Absorption is movement of material from the tissue into the capillary. So of course we have things such as oxygen, glucose filtering out, things such as CO2, potassium, etc., that is being absorbed. And it's a way of trying to maintain the homeostasis for the tissue that capillary bed is communicating with. What we're trying to do is to distribute extracellular fluid. Now, the most common mechanism of this is going to be diffusion. Things moving down their pressure gradients, moving down concentration gradients. And of course, lipophilic substances are going to cross the membrane very easily because they dissolve in the lipid component of it. And lipophobic substances will have to pass through pores. So lipophilic substances can move fairly easily across the membranes. Other substances are going to have to move through the pores. It's also what's called transcytosis, that we have some proteins that are what we call exchangeable. That is, that the endothelial cells will actually transport them across. But they're not going through pores, they're actually being carried across. Now we have to talk about Starling forces. Don't confuse this with the Starling law of the heart. The name is due to the physiologist, his last name was Starling, that studied both systems. So these forces are the forces that affect bulk flow. That is, movement of material from the capillary into the tissue and movement of material from the tissue into the capillary. These are hydrostatic, and there are two forces, hydrostatic and osmotic pressures. The hydrostatic pressure is the force due to the fluid. The osmotic pressure is the force due to what we call non-permeating solutes. That is, things such as proteins. They can't get across the membrane very easily. So we have two types of pressure, hydrostatic and osmotic. But we have two areas. We have the capillary fluid, or the plasma, and we have the extracellular fluid outside the capillary, or the interstitial fluid. So the hydrostatic pressure in the capillary, due to the blood pressure, and then the hydrostatic pressure due to the interstitial fluid. Obviously, if you have fluid leaving the capillary, it's going to build up fluid pressure here in the interstitial fluid, as well as when cells are metabolically active, they produce CO2 and water. So water is going to build up. It's going to have to be absorbed. So capillary fluid or hydrostatic pressure favors filtration, the movement of material from the blood into the interstitial space. Hydrostatic pressure of the interstitial fluid favors absorption, movement of material from the interstitial fluid back into the blood. Osmotic pressure, we have proteins that are inside the blood vessels, inside the blood itself, and we have some proteins that are outside in the interstitial fluid. And those proteins cannot move readily across the membrane. If you think about it, you have certain quantity of proteins or concentration of proteins in the blood coming in. As water starts leaving, you're actually going to build up the osmotic pressure within the capillary. Or as water gets absorbed from the interstitial fluid into the plasma, it's favoring, circle the wrong thing, favoring absorption. So these Starling forces, there are two basic forces, but there are two compartments, plasma an interstitial fluid. So you end up with a total of 4 different components that you have to be concerned with. And capillary hydrostatic pressure and the interstitial fluid osmotic pressure both favor movement of material out of the plasma, which of course would be filtration because we're filtering material out of the plasma. The the osmotic pressure in the capillary and the hydrostatic pressure of the interstitial fluid both favoring absorption, bringing material back into the capillary. So we have this hydrostatic pressure gradient that I've been talking about. Capillary hydrostatic pressure is capillary blood pressure. So the blood pressure at the arteriolar end of the capillary is about 38 millimeters of mercury. And on the venous end is about 16 millimeters of mercury. This favors filtration. There's more fluid pressure inside the capillary than there is outside. So that's favoring filtration, the movement of material out of the plasma into the interstitial fluid. The interstitial hydrostatic pressure is minimal. So if you think about it, at the arteriolar end, you have 38 millimeters of mercury inside the plasma or inside the blood vessel versus maybe about 1 outside. Even at the venous end of the capillary, you have 16 millimeters versus 0 to 1. So there is always a net pressure moving fluid out of the capillary. But of course, as fluid moves out of the capillary, what's going to happen to the concentration of proteins that are in the plasma? It'll increase. So let's take a look at finishing up the hydrostatic pressure gradient. So at the arteriolar end, we have 38 minus 1. At the venous end, we have 16 minus 1. So all of this is going to be favoring the movement of material from the plasma into the interstitial space. Actually, let me back up here. So this needs to be corrected. That favors filtration. The osmotic pressure, capillary oncotic pressure. Oncotic pressure refers to osmotic pressure due to proteins. It's about 25 millimeters of mercury. So it's going to favor absorption of material from the interstitial fluid into the capillary. The interstitial fluid oncotic pressure is fairly low. It's going to favor filtration. But the difference between them, 25 minus 0, gives you a net force favoring absorption of material from the interstitial fluid back into the plasma. So let's take a look at this. We have the hydrostatic pressure of the capillary and the interstitial fluid oncotic pressure, both favoring movement of material from the blood supply into the tissue, into the interstitial fluid, favoring filtration. But of course, the filtration is favored more at the arteriolar end because that's where hydrostatic pressure is greatest. As fluid starts being lost due to hydrostatic pressure, there is less hydrostatic pressure. The proteins that are within the blood become more concentrated, so that by the time we are moving toward the other end of the capillary bed, we now have fairly concentrated proteins, low hydrostatic pressure, which is going to favor filtration. So we have what we call a net filtration pressure, and it is basically the sum of these 4 Starling forces that we talked about. So the net across the capillary favors filtration over absorption. It makes sense. The body tissues are consuming substances, consuming oxygen, energy supplies, etc. So we're filtering material out of the blood into the tissue. But of course, there's going to be some absorption of metabolites, etc. The net filtration per day is about 3 liters. So it's one reason why we need to keep consuming water, is that overall we're losing about 3 liters of water a day into the tissue. The cardiovascular system consists of the heart and vessels. The circulatory system is the heart and vessels and lymphatic vessels. The lymphatic vessels are